Okay, hello everyone, welcome back. Let's get started with our afternoon sessions. I just want to do a quick conference goers voice survey. Raise your hand if you thought the barbecue at lunch was excellent. Great, yeah, there's no other option. Yeah, so unfortunately, if you didn't raise your hand, you've refused, sorry. It's just non-response. Welcome back. I'm delighted to introduce our next session, which is focused on the evidence to policy pipeline. For our next session, I would like to introduce Dr. Kevin Croke, a longtime Quest collaborator. Dr. Croke is an associate professor of global health in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health, where he's also director of the International Health Systems Program. Over to you, Dr. Croke.
Thank you, and thanks to everyone for joining this session. I'll just start briefly with, we heard in the last session about a paradox. And as I was thinking about that, we had the paradox of the People's Voice survey in the US and sort of things that don't quite match or don't quite seem to make logical sense. And as I was thinking about this panel, there's another paradox that this brings to mind, which is that we are all health system researchers. We take on research questions and we do our best to answer those questions. We try to bring as much rigor as possible to our scientific research. But we do it, the conference is science for health systems. It's an applied field. We do it to influence policy, to improve health. But once we have our study findings, we then start the process of policy translation. And the sort of contradiction is that we're often not trained at all in how to do that. So we take on difficult research questions, but at least we've been trained in research methods. We have all our tools to bear. And then we move to an equally challenging problem, which is getting policymakers to take up our findings. And there, I think for many of us, we find that we don't have the tools, we don't have the insights or the frameworks. So that's really the motivation for this panel. It's called Evidence to Policy Pathways, Insights from Different Disciplines. And we have 3 different fields of study, different disciplines, who, even as we as researchers sometimes haven't been trained in policy translation, their disciplines give them the training and give them the frameworks and concepts to enlighten us. And we're very lucky to have such a distinguished panel. So we'll start with Professor Ross Brownson from WashU, from Washington University School of Public Health. Professor Brownson is the Stephen H. and Susan U. Lipstein Distinguished Professor, and he's an expert in chronic disease prevention and implementation science, and a leader in the field of evidence-based public health. And really the field of implementation science takes, as one of its key challenges, policy translation. So we'll learn a lot from those insights. Next, we'll hear from Dr. Jacinta Nzinga of the Liverpool School of Tropical Medicine, where she co-directs the Institute for Resilient Health Systems and is also a researcher at Kemmery Wellcome Trust. She'll bring insights from health policy and systems research. So a sort of multidisciplinary global health field equally focused on policy translation. And we've been working together on some projects in recent years, and I've been observing, how she, puts policy translation into practice, and learned a lot from that. So I'm sure you will too. Finally, Professor Scott Greer is professor of health policy and management, of global health, and also of political science at the University of Michigan. And political science is a discipline with obvious implications for policy adoption. And I think, many political scientists, despite what you might think, it's actually my original training is in political science, and it's not a core question in the discipline as much as you might think it is, which is why we're lucky to have Professor Greer, who I think has studied these questions in great detail and with great insight. And so he'll also push us to think about some of the recent world developments that have made many of us think very hard and become, maybe a little bit depressed about the role of evidence in the policy process. So what's been happening, in the US and its implications for global health. So I'll hand it over to the distinguished panel. They'll each present their research and their reflections. We'll have a brief moderated discussion, and then we'd love to hear from you, your questions and comments for the panelists. So let me start by handing over to Professor Brownson.
Thanks, Kevin. I sort of feel like it's going to be nap time after lunch, so maybe get up and do jumping jacks or something first, and then we'll get into the part. So thanks for being back after lunch. I'm Ross Brownson, and thanks for the invitation to be part of this meeting. I think it's a great meeting, and so good to see 31 countries represented either in the room or online. So I'm a public health person. I'm going to talk about sort of public health policy, a few examples of that. All of my examples are from the US, but I think most of the approaches and lessons applying other places, the numbers might look a little different, but the approaches and the methods I think would apply. And keep in mind, my world is implementation science. Policy implementation has been studied in political science, I think, at least since the 1970s. Officially, as a part of the implementation science world, it's a lot newer. It's probably only 10 or 15 years old, but the discipline is also about that old. So it's becoming prominent. It is still understudied in the field of implementation science. So to get you going, make sure I got this working. I'm going to start with some big picture learnings, and I'm going to cover really the first two, the policy diffusion. I'm going to get in bed a little, then I'm going to talk one about a method of an agent-based model method. But there are multiple ways of sort of putting together what policy D&I research is. That's the D&I is dissemination implementation. So I'll probably kind of go back and forth between that and implementation science. There's formative audience research studies where you're trying to do something before you even formulate a policy to learn about an audience. There's related areas where you're numerically, quantitatively segmenting an audience. I'll give you an example of that. There's studies looking at how effectively you disseminate, how they receive, how people use it. And this could be policymakers themselves. It also could be intermediaries, the staff, or advocacy groups, or others who might be really influencing policy. There's how policymakers actually use the research when they make policy. And then the policy diffusion studies are whether something's effective, how are things spread. This builds off an old theory in diffusion of innovation by Ev Rogers, which is the original theory in implementation science. We heard about paradoxes this morning. The paradox in policy making sometimes is the inverse evidence law. If you follow the usual hierarchies of design, that the strongest designs are randomized designs, that's how we get our best evidence. Seldom can you study a policy and randomize to learn whether it works or not. So you're often using quasi-experimental designs, and yet policies have the biggest influences on our lives. So the biggest influence tied with our traditional designs doesn't really fit, and that's another paradox that we talk about. We also talk about both big P and small p policy. Mostly what I'll talk about is big P policy, governmental, officially laws and rules and regulations. Small p policy is what goes on in organizations. If you work in a public health agency or an NGO, and you're the lead of it, and you're making decisions about resource allocation, that's a policy decision. Policy decisions are made every day in organizations, and they sometimes get overlooked as one of the most important kinds of policy. Just to remind you, public health has come a long way. This is from a CDC publication several years ago on the top 10 public health achievements globally over the last 100 years, and I put 5 of them here. And many of these are areas where you work. Many of these we've seen great progress. We also have the potential for backsliding when policy changes. I want to also remind us that you take something like road and motor vehicle safety, it's not the policy only, it's also putting the word out about it. So this is an ad that went along with seatbelt laws. Never give up until they buckle up. So making sure that a policy is tied with other things and sort of a multi-level approach to making change. One slide on designs and different design options, because they're sometimes a little different than if you're studying, a randomized trial in a clinical setting. There are designs where you're collecting actual data, analyzing data retrospectively, where you're looking back on the policy. There's observational studies, either longitudinal or cross-sectional, that can involve collecting new data or analyzing data that's already there. Often that's administrative data, often collected for some other reason. For example, we study the effects of alcohol and tobacco policy by looking at taxation records on how much alcohol and tobacco was sold, and then we can do things like how many packs per person are being consumed without ever doing a survey to find out a smoking rate. So that can be very valuable data. Experimental randomized designs or quasi-experimental designs, most often in policy diffusion studies, these are not randomized designs. And then hybrid studies have become very popular in implementation science. All that means is you're studying the effectiveness of the policy on an outcome like a behavior change, but you're also studying the implementation in a setting. So for example, organizational change that might lead toward individual level behavior change. Framing matters a lot, and framing matters a whole lot. You heard quite a bit about this morning in the warm-up talks and the great panels. A lot of this comes out of communication world. They get to people's deep values, their deep beliefs, and how you frame issues. They enhance the messages, and when you frame a message properly, you evoke interest, emotion, and often action. And I'll talk a minute about the figure on the lower left, but an example of framing is often organized at 2 or 3 levels. So if you're trying to reduce mortality due to childhood cancer, there's this 80-20 rule in childhood cancer that in highly developed countries, survival from childhood cancer is 80%, and in low-income countries with lack of access to cancer care, it's only 20%. And so there's a big gap. And so a high-level framing of that is society ought to nurture its children. So that's level 1 framing. Level 2 framing might be, we know how to cure childhood cancer. For most childhood cancers, we can cure the majority of cases, so should we care about that? Level 3 would be, we need to fund this program. We need to pass legislation. We need to do something that more children and their families can get access to quality cancer care. The model on the lower left-hand side is just a way of segmenting audiences. This is from a model from 1949, believe it or not, from Weaver. And it makes sure we think about the source of a message, the message itself, characteristics of the audience, the channel, how we have the message reach the audience, and then in the outer part, the context. And in the examples I'll give you in just a minute, we'll be looking at different pieces of that model. And this applies to any kind of dissemination or communication, and is really important because often we only think of one part of it and we don't think about the whole framework. All right, so 3 quick examples for you. One, informative audience research, one an audience segmentation study, and then those 2 are big P policy. They're from state level policy in the US, and the third one in modeling small p policy. All right, so this is a recent study we just completed with local level policymakers. It's a randomized trial, so just when I said you can't randomize policy studies, here's a randomized trial for you. And this is formative, so this is before a policy is even happening. The question here was, how do we get policymakers to resonate better with evidence-informed approaches? And we sort of defined that for them. It's a 2x2 factorial design. We measured, going back to some early work from Carol Weiss, she talks about these decisionistic variables that influence policy change. That involves understanding, source credibility, use, and the policy context. All those are sort of nested in the study. And you can see the table shows the 2x2 was usual care. You just create sort of a typical policy brief. The risk framing is you create the usual brief, but you frame it differently in terms people will understand that sort of makes numbers more understandable. And then the lower left-hand quadrant is that you do a narrative, you do a story, but it's not using risk framing. And then the lower right is doing both. It's both conditions, the story and the risk framing. And I'll give you examples of the policy briefs we developed. This is on zoning and regulation. You could do this on any topic. And so this is kind of the standard brief. It's a little bit text heavy, doesn't have a whole lot of data. This is the kind of policy brief you often would see. The second is one where we tried to take, and we saw some good examples of the data this morning, where you put it into ways that people can understand it. You do comparisons, you make simple graphics, you show things in an easily understand way. And then the next one is the narrative, where we got actual stories from people. And the idea here was to learn about what evokes an emotion, what do people find credible, and then what might they use? And that was kind of the bottom line question. They liked all of our briefs, and there's some audience segmentation that you could look at. So for example, people who are more on the progressive side like the stories better. People more on the conservative side tend to look at cost data better. They look at things a little differently. The biggest bottom line part of it was that local data seemed to cross-cut everything. And when we presented with local data, which was part of that data presentation, and we asked them about it, they were 7 times more likely to use a policy brief if the data were local, regardless of all the other conditions in the data versus the story versus the risk framing. Source credibility, the higher they believe the source, the more likely they're going to use them. And then across the bottom, we've got some little snippets about how to find local data, how to develop materials, how to know your audience. And what we've done with these studies is we try to produce graphics and 1- and 2-pagers that will help people put the findings into action. So that's formative research. The next one is an audience segmentation study. I'll go through fairly quickly. I just have one slide on this one. But this is a large survey we did. It's 862 state legislators. And the idea here is to get across the notion that one size doesn't fit all. We have to frame differently. We kind of asked some of the same questions. This was generically about use of research in policymaking. We've also done studies on cancer, and we've done it on mental health, because each condition has different issues that come into play. So for example, for mental health, the issue of stigma is very important. And so you're trying to overcome stigma among policymakers. But in this study, it's a latent class analysis. And the part I want to highlight is that lower bullets on the 4 segments. So there are 4 segments. There's the pragmatic consumers. They're driven heavily by cost and cost effectiveness. They're lean toward ideologic conservatives, but they are driven by taking action based on cost. The uninterested skeptics, that was 30%. They're the hard group. They're not where you start. They're like the late adopter group. The highly informed supporters, they're the easiest group. They put a high priority on research evidence, and they put a high priority on stories. And that's 25%, so that's a pretty big segment. And then the lowest group are those who put a lot of emphasis, that's only 9%, on local data and listening to trusted messengers. Now, these aren't mutually exclusive categories, but what it tells you is messaging needs to be different. We've also looked at the correlations between these and things like party affiliation, gender, age, and geography, urban, rural especially. So it helps you think about, when you're segmenting audience, how you better target your messages. And then the last study I'm going to talk about, this is another 2x2. And this is a little complicated, but bear with me for a minute. So a lot of our work is with public health agencies. And these are small p decisions about use of evidence for small p policy, funding decisions, use of evidence-based practices in governmental public health. Misimplementation is what happens in the lower left-hand quadrant we call miscommunication or miscontinuation. And that is programs are continuing when they're not evidence-based and they want to stop. And that is about 25% of what goes on in a typical public health agency, according to multiple studies we've done. Mistermination is meaning we're ending things that should continue, which often is because of funding. And that one's a simpler one to understand. The miscontinuation it's much more important because it's driven by a larger group of complex factors like the political environment, my leadership wants to continue it. There's political support. So it seems like it's a little bit more changeable. And so we did an agent-based modeling, and we tried to look at some of the differences in these. If you don't know about agent-based modeling, agents in this case are individuals in the agency and the agency itself, and we're looking at all these complex interactions. This is a great example of the wicked problem kind of thing we talked about earlier, and that's where these system science approaches can be really helpful. We wanted to look at things that were actionable and would overcome some of the challenges that were going on in these agencies. And a couple of the important things we found was agency leadership really matters. How you communicate with agency, these sort of interorganizational practices, like how you communicate with leadership really matters. How they use information and how information is packaged. So we've come up with some actionable ideas that come out of this study. And this was done at the state public health level. We're working toward a new study at the local level as well. All right, so I'm going to end with a couple of big picture framings, then I'm going to hand it off to Jacinta. We probably need some new framing more than ever before. You think about here in the US, we can't really, in our large federal programs, we can't use the word equity anymore. So we've got to think of different ways to get to the same endpoint. We need to think about fairness or access, or like that first group, the economic benefits around policy. We've got to think about this idea of misimplementation. And now with some policies that are not good for public health, how do we foster more policy termination? And what's the score of that one? Because that one is very understudied in the public health field. We have a lot of gaps in the field of implementation science. I think it's almost an open playing field in a way. We're going to need to look to a broad set of funders on a lot of these issues, not a lot of news there. And we need to all stay in the fight. Sometimes it's demoralizing when you see what's going on, but it can be springtime as well. There's a lot of opportunities there, and we're going to need all of you more than ever before. So I'll say thank you and then hand off.
Good afternoon, everyone. Thank you so much for giving us the opportunity to share some of the experiences that we've had in this space in terms of talking about getting evidence into practice. I'll get my talk really focused on work that we, Kemri Wellcome Trust Research Program, which is an academic research institution in Kenya, has been doing in terms of doing both clinical health systems policy research and really working with policymakers to get these things into both policy and practice, or as Ross said, the small p. So our efforts in getting this evidence into practice has often occurred at various levels. So starting really at the micro level, at organizational level, which is mostly hospitals and health facilities, and transcending that across all the way to regional and international levels. And we've done this by following the policy cycle. So really thinking together with our stakeholders across those various levels about what to focus on during the agenda setting process, but also thinking together on how to respond during the formulation, and past the implementation, really thinking about how to adopt the things that we are seeing in better practice and to improve on those implementation practices. As a research program, we are about 30 years old now, but we have worked in the space of research for a long time, not really knowing that we were trying to influence policy. We were just trying to do good science and make sure that it counts. But over the years, we reflected as a program and developed what I would call a policy engagement strategy that focuses on those 4 interventions that you see there. Researcher embeddedness, knowledge translation, reciprocal secondment, where we are really working with the Ministry of Health to try and get either researchers embedded within the Ministries of Health to advance the research there, and vice versa, getting people from the Ministry of Health to work with the research programs to also understand how to do science. My talk today will mainly focus on the research embeddedness intervention. But the idea of our strategy as a program is to make sure that our outcomes really reflect and are able to show how evidence can be made more available and accessible to all levels of stakeholders in a way that is palatable to them, but also increase their capacity to search and use this evidence, and not just stop at the capacity, but also to think about how do we enhance their motivation to seek for this evidence themselves, even in routine decision making. But most importantly, throughout this whole exercise, we are very keen on building relationships, building new ones, but also strengthening, existing ones, because as I shall show you, that has been a central focus on what has made some of these things successful. So, as I mentioned earlier, our evidence engagement efforts often start with working together with these decision makers and implementers right at the formulation stage, really thinking with them together on what core questions to focus on. So it's great that we will have done, a fantastic systematic review to see what's the most pressing question, but then coming into the room to really criticize and agree whether that's the focus we should be focusing on. And that's really a very key element, that starting process. Working with the policymakers from the get-go is really fundamental, because what we've seen in practice is often as researchers and scientists, we tend to bring the policymakers in once we have our results. I wanted to present this graphic, and I hope it's clear enough, just to show or to illustrate to you the different ways we've been embedded throughout the health system. And in this graphic, I'm mainly showing how we are embedded at the national level, but also at the county level, the subnational level, which is the equivalent of districts. So there are various ways that we've worked with the Ministry of Health. I'll keep coming back to that, but it's mostly through technical working group and intersectoral coordinating committees, where a lot of our researchers within the program sit and are focused on different areas of expertise, all the way from health financing, vaccine development, and so forth. We've worked very closely, not just with the Ministry of Health, but other sectors that are involved in the business of producing health, including higher education sectors, where we are not just collaborating with them, but we are also using this research to influence curriculum. We work very closely, again, with political actors. Very key, there is the Council of Governors, which is the council that brings all the different 47 counties together. And we also work with private sectors and a variety of developmental partners. At the county level, the structure almost replicates. So I've just named two counties there that we worked with, but we work across a variety of counties in Kenya, and mainly through their departments of health and then through their health committees that are obviously the people who are in charge of steering health services within the county. All our engagements, really, the idea is to make sure that we have spaces where we are not just interacting with the policymakers, but we are enabling interactions between policymakers, between clinicians, the media, and that we are in the steering set of making these different groups of people talk together. So I'll jump straight on and give a few examples of work that we've done. The way I will do this is I will talk about three main levels. So the micro level, where is really the hospital and health facility work. And then I'll talk about how we've influenced things at the subnational level and then at the national level. So this slide just shows a couple of our colleagues who've worked in different areas for some years now. And they have collaborated with hospital managers, with medical schools, with the Ministry of Health, with international bodies, including the WHO, to actually contextualize some of these guidelines which have been produced as global evidence, but then adapt it to the Kenyan setting to make sure that it's realistic and that it's applicable. And those are some of the products of some of this work that has gone across different areas, including pediatric care, TB management, malaria, and pneumonia treatment in children. Now, within the program, our clinical research in hospitals has gone beyond demonstrating what clinical outcomes are possible through various interventions to taking that learning from that research to create spaces for learning and for benchmarking. This is the Clinical Information Network, which is a network of about 18 hospitals now and still growing. And the data from this, the way we've worked with the Clinical Information Network is that we do research in these hospitals on various things. Mostly we started doing work around pediatric and newborn care outcomes, but then get the hospitals to use that data internally. So they're able to generate data summaries, and then the data is presented, the data summaries is presented during mortality and morbidity meetings, and they identify action points for change within those hospitals. Every year we try and bring the hospitals together to show them progress in different ways, and there's no way to spur people to improve than comparing them. You just saw the report they had this morning from Todd. I'll jump on to what we've been doing at the sub-national level. During devolution in Kenya in 2013, the process itself was very rapid. And so there was a lot of confusion around how much autonomy these 47 sub-counties had. And there was still quite a lot of centralized control from the national government. During that time, we were actually doing some work in examining that devolution process as it unfolded, so really tapping into that policy window. And this led to the Department of Health in one of those counties coming to ask us to work with them to help them figure out how to use this new autonomy that was granted to them through devolution. And so working together, we were able to develop a county act for one of the counties, which has guided the delivery of health services in those countries in terms of operationalizing who has responsibility over what. A little bit closer home, in another county in Kenya, Kakamega County, evidence from the Lancet Health Commission, which Margaret presented this morning, was very instrumental in creating evidence that led this county to adopt and implement a maternal and newborn health service delivery program, which is the first in this county that was aimed at improving maternal outcomes. And we are just in the process of, together with Kevin, evaluating the impact of this service delivery approach. We've done more innovative work using innovations such as the learning sites approach, which is really a methodological approach where researchers are very closely embedded in the areas where they're working, and they work together with frontline workers or the key stakeholders to figure out what kind of support that particular set of people would like, and in our case, we were working with health managers, and we worked with them to examine how we could support them with everyday resilience in that county. This is in Kilifi County at the coast. Now, this led to the development of a leadership development program that was supporting the county managers, but also the hospital managers during a period where we had just transitioned in devolutions and people were not very clear about what roles they had in terms of being given that autonomy to lead these services. At the national level, there's research that we have, a very important research that we've done, examining the health system efficiency, and particularly that of the national health insurance in the country, and really looking at how it works. We were fortunate that a team of us were part of the technical working group that was sitting at the national level, and therefore they were able to produce papers around the reforms that were needed to streamline the purchasing arrangements for national health insurance in the country, which eventually led to the development of the National Health Insurance Act. Now, though things have slightly changed in Kenya now, this work continues to guide the new transition in Kenya from national health insurance to social health insurance. During COVID, because we had been able to demonstrate for a long time how we've typically worked with the Ministry of Health in doing our research, it wasn't surprising that we were then approached by the Ministry of Health to come and work with them in terms of trying to come up with rapid evidence that can inform the response to the virus. And there are a few policy briefs that are on there just showing the different topics that we were able to provide evidence on, and that really shaped the national response to the pandemic. I'll just finish off with this slide that just highlights a recently established knowledge translation framework that collects research evidence on health system transitions across different countries in the region, mostly in Africa. And this knowledge translation platform is known as the African Health Observatory Platform for Health Systems and Policy. It's in those 5 countries, as you can see. We, as a program, were part of one of the collaborators on this. And what AHOP does is that it provides a pathway for activating evidence by supporting policymakers to really use all the available evidence. So there's a collection of available evidence on different topics. And so what the network is doing is really giving policymakers the capacity to use that evidence and to summarize that evidence to guide everyday decision making. So I will end by thanking all the different people who've been part of this work. Most of them couldn't fit in the slide, but just to acknowledge that it takes a whole body of people to work together, and that whole range of disciplines are represented there. Thank you.
Hi, I'm delighted to be here. And Kevin already alluded to the fact that a political scientist is a beacon of joy. So before I start speaking, I also want to underline what the host said, and I'm impartial. I don't live in Missouri. This is an amazing city to visit, and I'm so glad that we're here and they're understating its attractions. So, we've been talking about data. We've been talking about the persuasive uses of data. We've had practitioners talk to us directly about ways in which making good arguments and use and deployment of good data can influence policy. This is pretty much axiomatic among researchers, but also in the broader public health community, partly because what else do we have, right? We don't have tanks, and we don't have tens of thousands of voters. We don't have that much money. Unfortunately, it is an axiom of a century plus of political science research that that's not how politics works. And there's issues that motivate politicians, political behavior, and there's coalitional politics, it's interest politics. Many of these interests are not ones that we approve of normatively within political science. And of course, it's political careers or post-political careers, which can also be big motivators. Now, a lot of the conversation we've been having here so far is about the characteristic ways that people whose main tool is evidence and data and social concern try to manipulate politicians who are not necessarily allowed to be or inclined to be motivated by broad welfare as evidenced by data. And this is partly because I'm looking at a lot of people in the room who I know a lot about politics. It's a commonplace of global health that you'll meet somebody who can tell you absolutely which factions are up and which factions are down and why the finance minister has a vendetta against the interior minister. And then everything they publish makes it look like they've never thought for 10 seconds about politics. We do this all the time, right? We adopt a technocratic language that disguises what we're talking about. And then you have to hire people like me to tell the students that that's not actually what we mean. We do accept the existence of politics. So, let's take a case study of probable interest to people in the room, which is the United States led massive reduction in global health, right? So there's a couple of pictures on the bottom about withdrawing from the WHO, and that's the removal of the US Agency for International Development sign, along with the removal of pretty much the whole Agency for International Development, which led a lot of people in the happy days of late January and early February 2025 to say, hey, maybe the Europeans are going to fix it, to which the Europeans responded with an approximately 40% cut so far in ODA for health. So it's not looking very good, right? And we're seeing not just the destruction of direct programs. There's a pretty good model that says that about 500,000 children have died so far as a result of Elon Musk's adventures in American global health policy. But also things that take a little more time to filter through. Organizations whose core funding was PEPFAR, which then did something else. Or people whose international funding allowed them to do additional things, to whether it was do activism or whether it was build additional services in a community, or have conferences and journals and associations that disseminate knowledge. So it's kind of a big deal. And I don't know if there's anybody who loved USAID at the beginning of 2025, but there's a lot of people who I would say miss it. It raises the interesting political question of why this was so easy, right? How is it that they managed to basically install a car salesman in a job that didn't actually exist and he fired 10,000 people, right? Like, that's not normally what the textbooks say politics is supposed to do. Well, due to the salience and importance of what's going on, we've had a real blossoming of opportunities to put cutting-edge political science into public-facing outlets. It's a great time for public scholarship when you can open your favorite media outlet and discover the political science consensus rendered as a front-page headline. Who is joking? Well, let's address this two ways. The first one is, why was the United States doing global health at all, right? And we can go through this list of reasons and see why it was so weak. Please notice very little of this has to do with evidence. There was Cold War influence competition. The Soviets were trying to lead a global effort to eliminate smallpox, so the US had to get in with something to show the superiority of the American way of life. There's domestic economic interests, farmers, right? It blows a hole in the economy of a lot of rural areas of the United States when you're not buying food to send abroad. There's one that's often understated, which is pro-aid interests within the Republican Party. Long ago, in the days of George W. Bush, who you see on the left giving a medal to Anthony Fauci, there was a very, very strong internationally focused evangelical interest in the United States on doing something about HIV. And that's the fundamental core of the party politics of PEPFAR. Well, let's just say that the politics of Christian evangelicals in the United States have changed quite a lot since those days, when you had, as Peter Hotez relates on the article pictured below, the kind of amazing buddy comedy of John Bolton and Anthony Fauci traveling around Africa looking for evidence-based things to do about HIV, which in retrospect is an amazing image. Furthermore, traditionally in the United States, once you've got something done, it's almost impossible to undo. Program termination in the American federal government is extraordinarily difficult, unless you're Elon Musk. Again, that's a thing that changed when we discovered that in our political system, we have a much more empowered executive than anybody knew a year ago. And finally, aid allowed us to, our politicians, to get photogenic images, look like they're saving people, economic interests, the farmers aren't the only ones who are benefiting, and also geopolitics. If you look at the way countries target their aid budgets, they're all doing it for various geopolitical reasons, right? You very rarely see it being done simply because of the net welfare from a program. Well, what is it that changed in the background? Well, the image I have there is of the decision to expand the presidential palace, which was taken without a whole lot of visible process. But what happened, right? A bunch of this is international. Inequality within countries really took off over the last decade after the response to the global financial crisis. Media ecosystems, you see concentration in legacy media systems, and you see the rise of extremely concentrated, effectively monopoly platform capitalism, which is, among other things, making it much harder for people to learn about their own local communities and economies. And then you have the particular trap that the United States is in, which is, it is one of the most two-party political systems in the world. There's as many party systems in the world as there are countries with elections. But the US has a very, very strong two-party bias. Which means that if you fire the incumbent, you hire the alternative. So in 2024, in an election where pretty much every incumbent government in the world lost vote share, and most of them, if they had an election, lost the election, well, by definition, the British got mad at their government and they elected a left government, and the Americans got mad at their government and they elected a right government. This is in a context of nationalized politics, so we've lost what used to be the case, which is that farm state senators would stick up for USAID, because now they're in a nationalized politics where sticking up for party leadership is what they're supposed to do. And you finally ice the cake with presidentialism, which is a well-known source of democratic instability, because you have a guy with a national mandate and an army, and if he has a fight with the legislature, it's hard to see exactly how the legislature wins. That produced the background which allowed the extraordinary behavior of the Trump administration so far. Well, political scientists might be shocked, but we're not too surprised. So here's to sort of end with a couple of ways that we think about this. namely the relationship between democracy and health and science. The first thing is that we have an ambiguous literature on the relationship between democracy per se and health, right? Does going through a democratic transition lead to better health? I think the literature is ambiguous because it's poorly done, because there's people who understand health variables, or there's people who understand political variables, and there's very few who combine them. So you see great political science arguments and data coupled with some download from our world and data that misunderstands life expectancy. Or you see really subtle analyses of morbidity and mortality coupled with an analysis of government so vague I can't understand what they're trying to say. This is a great research agenda. The literature is clear that interest group politics and coalitions are more diverse in democratic politics. That's almost axiomatic. Dictatorships don't like having a lively and diverse and politically engaged civil society, and in democracies it tends to happen. So the scope of conflict expands. The literature is also clear that citizens' opinions are broadly uncorrelated with anything that you might think matter. This is probably the most solid finding in the discipline of political science. I regret to inform you, what we do doesn't matter. Basically, people's vote choices are habit. I can tell about 2/3 of your political behavior by knowing how your parents voted. The things that induce people to make significant political changes, like from left bloc to right bloc, are more or less the same things as triggers of major depressive episodes, right? Sort of job loss, new family, major death of someone close to you, serious illness. Elites talk about politics and performance and punish each other for failure to perform or for choice of agenda. The voters aren't good at disciplining us. To the extent that the voters respond to anything, it's one variable, and it's household income growth adjusted for inflation in the 6 months before the election. That's it. On the bright side, and I put Gogol's Dead Souls as the cover if you can't read the rendition of the penguin, authoritarian regimes have an enormous weak spot, which is everybody lies, and everybody expects everybody to lie. People in the regime lie to the regime leadership lies to its officials, they all lie to the public lies to the regime, and they all expect to be lied to each other. And this is a chronic cause, not just of underperformance in all sorts of ways and corruption and so forth, but it's also the political weak spot for authoritarian politicians and regimes of any kind. So I'll leave you with some images that you cannot possibly find all 4 of them inspiring because you'd have to be completely incoherent, but they are left to right: an anti-Orban demonstration in Budapest a week ago, an anti-Trump demonstration a couple of miles east of here, an anti-Netanyahu demonstration, and a pro-Bolsonaro demonstration that, shall we say, got a little bit out of hand in Brazil. All 4 of them, you might say, are different fronts in what is substantially a transnational cold civil war over exactly what kinds of institutions and what scale of democracy we're going to be encouraging in every country in the world. And unfortunately, a lot of our ability to make good health policy or even study health policy well is downstream of this larger conflict.
There we go. I think you can all agree with me that we've had insights from different disciplines. They were widely varied, but very insightful, each in their own way. I'm going to do a quick round of questions, and then we're going to open for audience questions. I'm sure you'll have many, and just take this few minutes as we go through the panel to formulate your own questions. And I think people will bring around our remote mics for you to ask the questions. But let me go down and in the order that we presented, starting with Professor Brownson. So you've shown us, your work has shown us that implementation science offers powerful tools for closing the gap between what we know and what we do. But if you sort of take a step back, what's the biggest misconception that researchers or policymakers still have, even after all this progress in implementation science, about how evidence actually informs public policy?
And I can do both of those groups separately because they're different.
They both have misconceptions.
Yeah. So I think researchers, it would be probably that, at least some researchers, that research is the only thing that drives policy or even the major thing that drives policy. I think That is definitely a misconception. It doesn't mean that research can't be a part of it, because we've shown that's possible. It's just not the main driver. And then I guess the other one for researchers is often, I can't do this, I don't know how to do it, so I'm just going to kind of give up. And that's also not possible. Doesn't mean every researcher needs to charge off to the state capitol to give testimony, but they need to be active somewhere in the policy advocacy continuum. I think for policymakers, it could be something like researchers are out of touch, so why would I bother? Because researchers, like everyone else, there's some that are going to be very helpful and some that won't be so helpful. So it's not one thing. Or I don't, or I can't understand research. And a lot of that is not, we're going to have them read journal articles, but we're going to package it and transmit it in different ways, kind of that message and channel I talked about earlier. And then I think the last one would really follow on what Scott said. Something about, I'm only doing what my voters want me to do. And that's a misconception, because there's a lot of things that they're enacting every day that are not following what their voters want them to do. So that's on us and on everyone to try to get that closer to what the voters would actually like them to be doing related to health and public health. There's probably more, but there's a small list.
It's a good start. All right, Dr. Nzinga. Your reflections on embedded research highlight the importance of relationships and trust between researchers and the health system. But based on your experience working with Kenyan policymakers, what do you see as the key ingredients in building those kinds of embedded partnerships?
All right, thanks, Kevin. I think I'll just start off by just saying, I mean, the key around embeddedness and really getting embeddedness to work and be successful is not, it's a long journey. It's a long journey, and I started off by saying we are a 30+ years program, and it's taken us time to learn what works and what doesn't work. But that said, I think I can mainly talk about maybe 3 things that are really important in making sure that this work. First, very strong and clear communication, and the communication between the researchers and policymakers, particularly from the researcher's point of view, really making sure what the expectations are from each side, and having the grace to accept what the capacity of policymakers are. And I think there's always a lot of rhetoric about policymakers not being able to understand science or research, which is exactly that, a misconception. And so making it very clear what the expectations are of policymakers, but also of researchers, is very important. The other bit around communication is also just making sure that we are sharing our data as we go. I think as scientists, sometimes we become a bit obsessed with making the model perfect before we share. And we want policymakers to sit and wait until it's perfect. Meanwhile, the world is going on. Problems need to be solved, solutions need to be found. So there needs to be a balance in terms of keeping them informed throughout. The other thing is around mutual trust across both parties, and just an understanding that sometimes there will be failures, but there's lessons to be learned from those failures, and not being afraid to share those failures, whether it's failure from research we've done, interventions we've tried, or the failures are from the other side in terms of governments not being able to have the infrastructure or the capacity to adopt some of these evidence-based interventions and findings that we have. So that's important. Again, that goes back to my first point about realizing that even developing that mutual trust does take time. Yeah, thank you.
All right, Professor Greer. So say we accept this structural explanation of the relationship between evidence and policy, and I agree, it's what we teach in political science, right? We teach about public opinion, we start with converse, and we start with these sort of well-known and like repeatedly validated facts about how public opinion relates to to policy outputs. How should we as researchers take that? Should we think there's nothing we can do? Should the response be, I guess, a kind of despair, or is there some other way we could interpret this set of facts, this set of explanations?
You lose 100% of the games that you forfeit. Your average voter is basically like somebody who is dimly aware of a sport, right? It's like the people who get interested in football every 4 years for the World Cup. And this really drives sports fans crazy, right? Because you've got someone who doesn't understand the offsides rule and has kind of semi-randomly picked a country and is running around being the biggest fan of the Belgian Red Devils for a week. And voters are often, Jen, quite surprised when the election, this professional sport that they don't like, turns out to have results in their actual operative life. A lot of Americans are undergoing this process right now. It's as if somebody won the World Cup and then your taxes went up, right? Like, what just happened? But here's the thing. Even if a lot of the voters are a disappointment to sports fans, the team's still got to play. And that's what we're doing here. It is in many ways an activity of a political elite to make policy. And the reason that they care about data and the reason that they care about a lot of what we do is simply that we do have one compelling advantage, which is we can tell them what's going to happen on the basis of making a policy. Right? We can tell them about the likelihood that they're going to get that economic development or that they're going to preside over something incredibly embarrassing. And that's actually quite valuable for a lot of politicians. So that's the argument, is we're better able to tell them what the consequences of their actions are going to be. And the fact that you might not like the politicians you've got speaks to you as a citizen as well as a researcher.
Well, I think if there's one thing we can take away, it's the complexity of what we're trying to do as researchers. But I want to give the audience a chance to ask their questions. I know many of you probably have questions for the panel. So please just raise your hand and the mic will be passed to you.
Thank you much for the wonderful talks. I wonder if you could speak, I don't know if this, whoever can take, if they feel best about it, the difference between communicating or working with people, politicians and policymakers at the national level versus the local level, both in what sort of what role data can play, what things are driving their decisions, and then the impact that that can have on sort of national policy. Thanks.
I'll say a few words about that. So could be national, state, or local, but we'll just do national and local the way you framed it. I think if you start local, you more likely have direct access to the policymaker. You can see them, you can find them at events, you can, most policymakers in the US have different jobs as well, so you can find them at other sectors and you can have more informal conversations. At least my experience, they're a lot more accessible than national level policymakers are. They typically have smaller staffs, so at the national level, I'd say you have better access to staff members who, I think that's one thing behind the curtain that people don't know. Like, so many of the laws are written by staff members who are locked away in the basement of some windowless office that they're writing the policy and they're driving a lot of what happens for a policymaker. So if you can, and the national level, many of them are there for their whole careers in different, they tend to have party affiliations, but they're there for a long time. So I think that's different. I think that it depends on the frame of reference. So like a national level senator, their frame of reference is going to be a whole state, whereas a local representative, it's going to be much smaller. So it's also going to be different how you frame data, how you use data, how you show the impacts of their decision, I think, based on their frame of reference. But I'll let others chime in as well. Maybe from the
I'm on the spot from the political science side of things. I'll just say one thing, which is we underestimate how useful goalies are. Shooting down bad ideas, or at least making it clear that they're not going to have the desired effect, is a really, really important function in policy. And we get seduced by what was the great innovation that we came up with that got adopted and worked. It's like, well, also get out there and fight the good fight. Let's have fewer stupid pay for performance regimes and fewer stupid user fees. Someone's got to get out there and say it.
More questions? I see a hand in there.
So thank you so much. Lisa Hersham from Northwestern. One of the things that I learned actually when working with Margaret and Mohammed on the high quality health systems was the distinction actually between a policymaker and a politician. And to some extent, the messages that they want to hear and the time frame on which they focus, and potentially also the sustainability of the change that you might actually be making. And I'm wondering if you could talk a little bit about, further segmenting, because I've heard a lot about policymakers and politicians in the same word, and I would really be interested to hear about that. And just to hint up, we call it perfectly good enough evidence rather than perfect evidence. And how do we actually frame that for these some further segmenting the audience? Thanks.
Yeah, sure. Thanks for the question. I think I'm going to reflect on our context. Often, our policymakers are politicians. So that's often, it's a binary. And they will, at whatever level, whether that's at national level or at the subnational level, they will have specific interests and drives. And what we have found from my experience is it's important to understand what those interests are and whether they are reflected in the political agenda that they're fronting either as parties or as a new government, and making sure that the language within which you are providing that data aligns with some of those visions that they've created for themselves. So that's how I'd put it. And then in terms of segmenting the data to speak to those different audiences, again, it just goes back to really reflecting again on what those specific interests are. And we have found that, for example, at subnational level, there has been greater appreciation of them seeing the whole set or the nuances of the granular data itself before it goes to national level, particularly because of the issues around Kenya now in the political scene with being devolved and giving them that autonomy space. So there's usually a form of unkindness that they take to when the data is presented at national level and they haven't seen it themselves and interrogated whether it feels right for their settings. And so we've been careful about just making sure that we are going local first and then going up. Thanks.
I think one issue around being able to effectively segment audiences is the quality of data you can get. So a politician may report differently than, at least tell me exactly how you think, what you were saying the big differences you would use in those two words before I can repeat. Yeah.
Or somebody who's in a Ministry of Health versus somebody who actually is going to be elected.
Yeah,
and
okay.
therefore is potentially in a different cadence, shall we say,
Yeah.
than somebody, and also a different audience to whom they actually are speaking.
Yeah, so probably in what I was saying, like a small p or big P policymaker. So I think that the small p policymaker will be driven more by things that we typically would drive policy. And then I think that you could probably get more accurate data on small p policymakers than you call on big P policymakers. Most of the surveying and studies we've done with elected official policymakers, what you call politicians, I don't believe quite a bit of the data we get from them because you have very low response rates and they know a survey's coming from university. Like we've got surveys where they say they trust universities the most in terms of where to get evidence. I don't believe that. And then they'll say, I put low value on interest groups and lobbying groups and donations. And so, number one, who are you sampling? And number two, is it social desirability or other pressures they're answering? So I guess probably take with a grain of salt what you learn from what you're calling the politician group is also pretty important. I think segmenting, and probably fewer segments in the policymaker group as you label them compared to the politician group. What we found in some of the politician segmenting we've done is there's a lot of segments. Some of the data are pretty easy to get for the segments and some are much harder. You'd like to find things that are easier to get so then you can target your messages better.
I think we have time for maybe one more question.
I do have a question from our online attendee. In this difficult environment for global health research financing, who should or who does fund research on making the pathway from evidence to action work?
Got a lot of answers for should.
So the question was on the funders for research.
I think is for global health research financing in general, like who should or who does fund research on making the pathway from evidence to action work.
Can I try? This is hour zero for global health, substantially. The geopolitics of the world were already changing radically before 2025 happened. And the last people standing who you would expect to continue to support it as it was, which is basically the Europeans and Bill Gates, aren't necessarily taking the direction that they would have taken a year ago. So I think the way to do it is to do two things. One is to reconceptualize research, right? What exactly is it that we need? Do we need more RCTs? Do we need more dissemination of information? Do we need practitioners to talk to each other, right? So think a little more creatively about that. And then the politics of today aren't going to be the politics of forever. So think about what you want to advocate for in whatever country you are in as to who should be doing what kinds of research should we be paying for, and why. So think about the future. It feels good. And it's useful.
And I think the other part would be just find funders who care about the economics of health and really focus on some of the economic drivers and how important that is for any society, and see if that might level this out a little, because I agree, it is a very difficult time for all health-related research and practice, but especially in the global context.
So I think we're just at time now. I'm sure others might have questions, but I'm sure the panelists will be happy to chat with you, throughout the whole course of the conference. So please join me in giving a warm round of applause to our panelists.
Wow, that was a roller coaster. I laughed, I cried, I'm not sure how I feel. The diverse perspectives on this policy, evidence to policy pathway, very fascinating. Thank you all so much. It's now my absolute pleasure to introduce our first keynote speaker, Dr. Ann Kurth. Dr. Kurth is president of the New York Academy of Medicine. She is an epidemiologist and a certified nurse midwife whose research focuses on HIV and reproductive health and global health system strengthening in the context of pandemics, climate change, and other stressors. Previously, Dr. Kurth was the dean at Yale School of Nursing and professor of epidemiology of microbial diseases at Yale School of Public Health. After Dr. Kurth's talk, we will have an opportunity for a discussion in the room, facilitated by WashU's own Dr. Mark Huffman, who's the William Bowen Endowed Professor of Medicine, Professor of Public Health, and co-director of WashU's Global Health Center. Please warmly welcome Dr. Ann Kurth.
Well, it's wonderful to be here. There's incredible wisdom in this room, and I'm really excited to draw from it and learn more over the next few days. So thank you, Margaret, and everyone for the opportunity here. And I'm going to continue the theme of looking for shoots of green in these highly turbulent times, because we do have many tools that can help us navigate the trends ahead to keep pushing for healthier, longer lives for all. That's basically my bottom line. Also, please submit any articles you have, great science, in the Journal of Urban Health, which New York Academy of Medicine publishes, which does look for global examples around the world of urban health. Here's what I'm going to just say, okay? Urbanization is with us. 80% of Americans live in cities. More than half of everyone around the world lives in urban settings. We're in a world that is both aging in terms of demographics and also warming in terms of climate change. So how do we think about healthy city design and everyone's role in making for healthy city life, urban life? Because our goal is, as always, is to get to not just longer lives, right? Not life expectancy only, but healthier lives, compressing morbidity and having healthier lives for longer. And we want that for everybody. So that's health equity, right? And we've already talked about how we like to put health systems front and center. Most of us are part of health systems or have been in our time. So incredibly important, and yet actually not the major player in driving health, right? Realistically. And so we have to think about all the other social and environmental and commercial determinants of health. And how do we take what works and contextualize it in other settings and try to get more scale of impact? I think that's certainly been a theme here. So just to talk to these trends a little more, we know that we've already passed that curve between majority of populations in urban settings. We know that many of the cities that we'll have in the next decades have not even been fully built yet. So there's an opportunity, right? How do we think about the built environment for cities that haven't even been built yet and that will expand rapidly? We know that the population that is 60, 65, 85 plus is growing dramatically, and that requires opportunities for supportive environments to deal with what's been called the silver tsunami or the silver wave. You can ban phrases, but you can't ban physics. Climate change is here, it's accelerating, it has impact, particularly in cities when we think about the urban heat effect and coastal cities, and many people live in coastal cities. And we know that that disproportionately affects populations that are already made vulnerable. But there is opportunity, again, to design both the way we deliver our healthcare, prevention, public health, and city infrastructure itself. So we talk in New York City, I'm a New Yorker, so I'm going to speak to some of that. We have an age-inclusive, age-friendly commission that we chair with our age department. And we talk about age inclusivity. Because how can we think about making all of our living spaces and cities be more age inclusive? And these are some of the opportunities and elements that we should deliberately be thinking about. WHO, of course, has thought about this as well, age-friendly, age-inclusive environments. When we have diversity that is brought by older adults, how do we address those inputs and needs, and particularly protect the vulnerable? So I was asked to speak a little bit to the US examples. And so again, I would say that you all probably, wherever you're living, you probably know the demographics, but we do know that our population is aging. And in New York, we're actually sort of already where a lot of other cities will get to in the United States. We already have 1 in 5 or 1 in 4 of our population are 60 plus. And we know that there are economic stresses in this group. There are racial and economic disparities exacerbated by educational problems, disparities as well. So the boom has dropped. Every baby boomer you know is already 60 plus. And the 85 plus group that tends to be more medically frail is actually going to grow most rapidly of all. So as health systems, we need to be thinking about this population at all levels. So anybody here working in an age-friendly health system? One that's been designated? Okay, so there is a whole set of criteria and tools for this. This is an initiative of the Hartford Foundation. The IHI and AHA are now also engaged in this. And there's about 5,500 health organizations, hospitals, long-term care facilities, et cetera, that are doing what is called this age-friendly approach in their health system. Check out their website. They have an ROI calculator on there, so you can kind of even look at what some of the elements would cost you to do potentially in your health system. They started with the idea of the 4 M's that matter. People have now added a 5th M, which is to say multi-complexity, multi-morbidity, right? Which is certainly a feature in these populations, but it's about addressing, obviously, brain health. It's about addressing what is important, what matters to people most. It's about addressing micro and macro mobility, and also medications. And of course, obviously, polypharmacy continues to be an issue. So we've been trying to stay away a little bit from AI, but is that our future up there, the AI clinician that's coming? I've heard people say AI has the possibility to bring back the joy in clinical practice. We're also, I think, a little nervous about whether there are boundaries and guardrails, right, in many levels. Or will we have still a more person-centered system, and can AI facilitate that for us by freeing us up? And we're moving away from just back office use of AI. Obviously, people are looking at how much can it be used for actual diagnostic pathways, treatment pathways, although we also heard this morning, what do you do when you have different algorithms telling you different things that don't jibe? But could it help with a more person-centered approach? Digital forward populations, as we know, are out there, certainly amongst younger people, to finally deliver that actual personalized healthcare. And we know that we don't have the workforce to deliver much of the care that we need, and certainly that older populations need as well, including in the mental health space. You heard it multiple times already. You all live it every day. We're not producing enough faculty and healthcare professionals at all levels, and that's not likely to change tremendously. Can there be some innovations that we think about in that space? We've talked about amazing new medication classes that have come along, including potentially the wonder drugs of GLP-1s. Can they solve everything? Can we get to a generic oral version of it that's affordable? We'll see. But versus straightforward traditional classic prevention that we know is needed, primary care prevention. People are expecting to have more of a digital world, and that includes for healthcare delivery. They want it 24/7, and that's going to be more digital delivery. In terms of the shifting models of care and the economic pressures that health systems face, certainly in the US, where there are economic, in terms of consolidation, private equity's role. We know that rural hospitals are at risk of closing in many parts of the US. Tremendous concern about the Medicaid cuts that are coming, what that will do. The shift to more ambulatory and in-home-based care brings some opportunities. It also means that inpatient care is going to have a higher acuity, right? So thinking about all of these elements, where do we pull innovation from it rather than just stresses? And again, who's heard of the phrase health span? So, it's not a totally novel concept, of course, but it's that idea that, again, healthy birthdays. How many healthy birthdays can you have before there are chronic conditions or more disabilities? And so at New York Academy of Medicine, this is one of the things we're focusing on, the push for healthier as well as longer lives for everyone. And there is an equity element there. We know we have to look at all of these issues of social determinants. We think about that in terms of what we push for, in terms of our urban design, in terms of the built environment, in terms of services. And so many of those built environment changes at small and large levels can help every population, not just older populations. So curb cuts, we all like those in our sidewalks, right? Those are innovations that were put in place in many regards initially for older populations and populations who needed that, but it really affects everyone. As we think about climate change and its impact, we know, of course, that both the very young, outdoor workers, pregnant people, and older populations are at risk of the immediate health impacts of climate change, and certainly with heat waves. Remembering that actually most heat deaths occur outside of the heat wave itself, right? So you have to be anticipatory about that, and thinking about where the risk is. We, for example, have a mapping project that we do with CUNY in New York City. So we were able to look at all the different elements of where our older populations are living, really at a very micro level, and where is the heat risk, where's the electrical electricity and economic security risks and other parameters. So we're trying to sort of be aware of how to map it out in our own city. But coming back to health span, this idea of healthier and not just longer life, we know we can thank public health, right, for many of the advances the incredible advances in longevity that have occurred globally. And that took a dip in COVID, but have come back. That was certainly the case for us in New York. But really, the percent of life and the years of life spent in a healthier way has really not moved much. And so I think that's the opportunity that we should be thinking of. And the goal is what we would all want, right? Live as healthy as you can for as long as you can before you die, rather than a slow decline. with all of its decrement in quality of life and costs. And of course, in the United States, we are a nation that has multiple, comorbidities and NCDs. Globally, it's also true that we live a fairly large chunk of our lives in poor health, basically. So we want to address that gap between healthy years and end of life, and that gap in the U.S. is about 13 years. It's about almost 9-10 years globally. And again, minding and mending that gap have to be looked at in a very comprehensive way. And it's really about birth justice, safe birth, all the way through to reducing NCDs into young adulthood and working life, and healthy aging as older populations. And really, we have to teach young people today to become centenarians. How do we design things for them to live to that healthy longevity that we all want? So we really do have to think about these demographics. As you see here, almost everywhere populations are aging. Are the health systems that are already strained ready for this? And we have to really think about not just the silver tsunami, but how do we empower older people so that we have a silver dividend? And really, it can be done. There are some examples, not everywhere yet in total, but as we think about policy, we just had that great session on policy and investment. There are cities and countries that are trying to invest specifically in improving health span and scaling up the modifiable factors, looking at what drives the health span extension. And of course, there's an important need to address mental health, really for every population and every life stage. Singapore has done a really interesting job in this space. The Deputy Minister of Health there tells me he tracks his health span metrics every month. The UK, the NHS, of course, one of the advantages of a national health system, they're able to integrate clinical data with population level data, and they are tracking health span. They've made some policy goals to improve that. Other countries are taking a look at this and trying to really set metrics, or at least track metrics of opportunity improvement. In my own city, in New York City, our health department has set goals of what they call in Healthy NYC, which is looking at really 10 drivers of less healthy, less long, or healthier and longer lives. So we're actually trying to frame our work in the city in that space. And of course, again, we believe that the health sector is crucial. It is, obviously, it's 20% of the GDP in the United States. It's a huge factor for employment. Health workers are still a source of trust as we think about politics and policy influence. But it certainly helps when there is more explicit investment specifically towards what can improve health span. And a lot of that would be a focus on primary prevention, as we've talked about being important. Private sector has a role to play as well. I don't know if you all have looked at the Stanford life map. So if we have a centenarian life, which many babies born today will live 100 years, right? It means we should have the opportunity to spread out a lot of life events a little more, ideally, right? Child rearing, elder parent care, working, can we spread it out? But it also assumes that we'll be working for at least, 40 to 60 years. So there you go. That's going to be part of the centenarian life. But can we spread it out a little more and think about what people need at different stages? And of course, this is an equity issue, as with so many other parameters in health. This is just like using HALE as one measure of arguably of health span. And of course, there is enormous range across the continents. So addressing structural determinants and environmental determinants, Sir Michael Marmot actually has outlined some of the principles for urban design that would result in healthier longevity kind of cities. And there are cities in the UK that are actually trying to embed this into everything they do in their city. And as we've said before, it's really important to have the broader view because zip code can be more influential than genetic code. So my workplace with the Federal Reserve Bank of New York, we always do a Healthy Longevity Cities event every year, convening. So last year we had Sir Michael Marmot talk about this. So these are the principles. Is your health system or a health system able to have some influence in each of these elements? I would argue yes. Safe birth, right? Maximizing health at every life stage. Employment, even health workforce is a big employer. Pushing for policies that improve health for all. Being engaged in communities. Those of you in the US who have to do the community health needs assessments every 3 years, you can think about tracking some of these data points and elements. And we've actually added in our community health needs assessments in New York, we've added climate change questions now because that's part of the environmental factors, right? That will influence healthier, longer lives. Obviously addressing illness, structural racism, and pursuing health equity as the overall framework. The other opportunity that health systems have for healthy cities with all the trends that are coming is to redesign. And we've talked a little bit about the need to move more towards primary care and prevention so that we're not delivering just sick care with all of its energy utilization. So that becomes actually a climate change initiative. And that would make for healthier systems, and it's really what people want as well. So just to close, let's not forget that we need to be thinking about the impact of climate change, both how we green up our health systems and become adaptable when we are hit with crises. This is not a standalone separate effort. This is part of the quadruple aim, okay? This is about safety and quality in healthcare. So hopefully you can have leadership in your health systems to address the stresses that climate change will bring, just as a part of your core mission. And that's just my last bit, and look forward to any questions and ideas and thoughts from you all. That's it.
Coming from behind, yeah. Thank you very much. Thank you very much for that presentation. You spoke a little bit about the New York context, but tell me a little bit about the international context, as we've got people from all over visiting here in St. Louis for the first time.
We absolutely do, and I would love to actually hear. Yeah, I would love to actually hear some examples of, because we do have such expertise here in the room. There are, as I pointed out quickly, there are countries that are trying to set this health span goal, improving the health span goal specifically. But in some regards, it's a repackaging of the work we all want to do anyway of improving health while we extend healthy life. So if any of you have examples that you would like to move forward from some of your work in your settings, I'd love to hear it.
Any takers? Yes, thank you.
Thank you very much. My name is Jose Maria Chema Valderas, National University of Singapore. You already mentioned Singapore as one of the examples, and it is indeed the case that the Ministry of Health is setting it as one of the priorities. As Singapore has achieved a new blue zone status, or was acknowledged as such, recently. By that it means one that would not necessarily be the result of a natural environment, but rather one that has been achieved by design. And the priority is indeed healthy longevity. There is you were mentioning the issue of the built environment, and one of the neighborhoods in Singapore is currently being redeveloped, having healthy longevity in mind, considering how the communal spaces in the high-rise HDPs, that's the public housing. I mean, most of the people in Singapore own their homes with, that's I think one of the things that explain the very high performance of the health system in Singapore, perhaps more than or at least to a very significant degree, as much as the health system itself. Just wanted to add this to your own comments. Thank you.
What's the discussion with the Federal Reserve? What's the Federal Reserve thinking about healthy longevity cities? That seems like to be pretty important.
So their emphasis is about having economic security and longevity. They see that obviously and understandably as a real pillar for long-term health, is that people have to have enough earnings or savings or entitlements to get them through, including through what is now a longer and longer retirement phase. And of course, the data, even as wealthy as the United States is on savings, is actually a little bit worrisome, frankly, and quite disparate by socioeconomic groups.
And so are they doing other sorts of events with other, I think of the St. Louis Federal Reserve also, and trying to think about what can St. Louis do to engage economic policymakers to understand that, I'm born and raised in St. Louis, and I'm a practicing preventive cardiologist here. So a lot of my patients, they want to live forever. And they come to me, and we talk a lot about healthy longevity. And yet, when I was a kid, I think about my grandfather was 92 years old and worked on the day he died. And so he was a really active senior person. And now I see St. Louis just feels older than many of the other cities where I might travel or visit. And so I think getting some of these economic policymakers to recognize the importance of addressing this, and also the value of having our elders. I mean, that's one of the reasons why I'm back in St. Louis, is because of the elders in my family. So yeah.
Yeah, you're right. It's a national network of policy influencers, the reserve banks, and it certainly has a key role to play in health.
Great. So what questions does the audience have for Dr. Kurth about healthy longevity cities or experiences that you have in your cities? No, please.
I have a question. Yeah, it's on. Oh, okay. A question. So New York is an old big city. It's been a big city as long as humanity's had big cities. And so there's a whole lot of infrastructure there that's already in place. How do the priorities look for old big cities, the New Yorks, the Londons, versus the cities that are rapidly growing and building new infrastructure now? Sort of, how would you nuance your advice for the two different situations?
Yeah, it's a great point. The thing we love about New York, of course, is it's also a microcosm of the world. Everybody from every nation comes, so there's a lot of idea generation and people push for those ideas. A couple of thoughts come to mind. One is it is more expensive to sort of maintain and retrofit expensive buildings, right? And yet it has to be done. So I was at NYU during Hurricane Sandy, and my nursing colleagues were the ones who were bagging the babies from NICU in the dark hallways and putting them in taxis to send them to hospitals on higher ground in New York. Now we can do better than that, right? So we are doing more planning, but thinking about the physical infrastructure even of our hospitals. NYU, of course, spent $1 billion to harden its facilities. And what used to be Coney Island Hospital, now called Ruth Bader Ginsburg Hospital, did the same, because they are literally on Ocean Avenue. And during a storm, the street became an ocean. And there were actually turtles in the IT room, and there were, fish in the emergency department. So they have also had to sort of look at doing infrastructure work like being able to raise walls up, putting mechanicals on higher floors. Some of the things that people can do de novo if they're starting out with a new building, but might have to be worked in as building improvements happen, as facilities get rebuilt, and searching for the funding for that is a challenge, because we had the Inflation Reduction Act that was really spurring a lot of that. We no longer have that in the US, and yet people still have to replace boilers and have to replace windows. And so there is opportunity with older infrastructure to think green from the start, and there's ROI on it.
Great. In the back, Professor. Oh.
I just had a question about the climate change implications that you were talking about for healthy longevity? Like, is there something in particular that institutions should be working on in order to promote health span for individuals, like from a climate change perspective, other than like the infrastructure like you were talking about?
Well, heat's a good one. Heat is going to is already the most direct, the largest direct cause of morbidity and mortality related to climate change. So thinking about how to protect pregnant people so that newborns get a safe start to life, frankly. Thinking about protecting older people who, of course, are physiologically more vulnerable to heat effects. Our city health department actually distributed air conditioners as a public health intervention, for example, right? And we needed to know where the folks were that didn't have air conditioning. That's why we do the heat mapping, and that's an example.
Professor McBride?
Thanks, great talk. In terms of healthy aging, and you had a slide up earlier, talked about workforce, and the fundamental problem with aging in the United States, at least, is we're gone from a dependency ratio of 5-to-1 to 4-to-1 to 3-to-1, it's going to 2-to-1. So who's going to be able to take care of these folks? And, from an economic perspective, retirement used to be 0-1. You work and then you retire, but there's this new sort of encore career where people do something else after they retire from their first job. So what's the role of employment, either in the US or globally, after the first retirement or the second retirement? I've known people who retired 3 times, and how does that influence being healthy?
Yeah, no, great question. And again, that demographic shift, China's facing the same problem. Japan has already been facing it. Will we have the robots that Japan is increasingly bringing in to do elder care? Who knows, but it's certainly the case that informal caregiving is an enormous, unrecognized economic, probably opportunity cost. And I can tell you in New York State, we have a commission, the governor's asked us to create a commission on the future of healthcare. The amount of money that's been spent on family home care providers for older folks has just ballooned to a completely unsustainable way. So how do we thread that? How do we navigate that? The caregivers that you're saying might be coming in on their 3rd retirement. They're aging themselves, right, and need their own care support. So this is really a problem. AARP has looked at this, and others, but so both civic society and economic entities and health systems have to be thinking about this more broadly, is how will we deliver that care? Remote monitoring, right? There are some potential advantages with digital technologies, wearables, and remote monitoring, and yes, even, potentially physically assisting care, but we don't have all the answers yet.
Well, thank you very much, Dr. Kurth, for your presentation, for your questions, and talking about this topic of urbanization, climate, and aging. These are really big forces that are influencing healthcare, and health systems.